What our group did was we utilized our large Gemini database here at MD Anderson, which has clinical information about patients and their diagnosis, particularly who have non-small cell lung cancer. And we isolated patients that we identified as older adults, so age 70 or greater. And we looked to see in these patients who continued with immunotherapy beyond documented radiographic progression, what were their clinical outcomes? Why were they continued on therapy? And what we found was that there actually was a clinical benefit in a select group of older adult patients who continued to receive immunotherapy despite that first documented radiographic progression, whether it was because of pseudoprogression or whether it was because the provider and the patient, after an extensive shared decision-making conversation, felt that the patient was still deriving clinical benefit. I don't think that these findings are ready just yet for prime time, real time. We really still need to identify biomarkers, either patient characteristics or disease characteristics, to better understand which patient subset or subgroup of patients may benefit from this treatment strategy. Another really interesting concept that we looked at was that some of these patients who continued to receive immunotherapy beyond documented radiographic progression, they actually received local consolidative therapies or local radiation for oligoprogressive sites, and then were able to get back on immunotherapy. So can we use a multimodality strategy to really continue a certain particular systemic therapy for our patients? That's the prime question, but identifying the best subset of patients who's going to benefit from this treatment strategy has yet to be determined.